Is there a possibility that there are variants that are maybe not getting picked up by the RTPCR test?
It's very unlikely that all 3 genes will not be identified for this variant. I think a more likely situation is the quality of the tests that are being performed. When you expand from 0 labs to 2,500 labs doing RT-PCR tests, there will be variations in quality.
Doctor, could the deaths we're seeing right now, could many of them or some of them have been avoided with better preparation?
Are there preventable deaths happening today? Have they happened in the past? Absolutely, there are.
Well, India is in what can only be described as the worst public healthcare crisis we have ever experienced in the independent history of this country. There's so much confusion right now. But apart from many, many other things, there is one route out that most scientists seem to agree on, and that is vaccination. Effectively, India needs to focus on controlling the spread of the virus, looking after the people who are hospitalized because they have very severe symptoms, and vaccinating a large portion of our population. Now, the process of vaccination has again drawn up many questions among you. So many of you have sent in your questions, and our attempt is to bring in the best experts to answer your questions for you. So I'm very pleased to say we've managed to bring in a wonderful expert who I've personally been trying to speak to for many months. So I'm really glad we got this time together. Joining me right now is Dr. Gagandeep Kang. Now, let me do a quick introduction. She's a professor of microbiology at the Christian Medical College in Vellore, but she spent her career studying vaccinations for cholera and for typhoid, conducting large studies about test vaccines and their impact on the population. She's published over 375 papers in international and national journals, and she's the first Indian woman scientist to be elected fellow at the Royal Society. She's the first Indian woman to be elected to the fellowship of the American Academy of Microbiology. And she's kind enough right now to give us her time. Dr. Kang, thank you so much for speaking with me. You said in a recent article that you believe that this terrible second wave will begin to ebb or will begin to taper towards the end of May, or maybe in the beginning of June. Do you still hold that opinion? And will this happen without intervention, or will governments need to intervene and do something in order for this tapering to begin?
So it's not something that I said. I think I just channeled what a lot of mathematical modelers are saying, and they are the real experts in prediction. But I have reviewed a lot of models, and I hope I can tell the good from the bad. And among the ones that are good, what they are predicting is peaking shortly from now, and then a decline following that. There is, of course, a worry that if you're not testing, you can artificially create a peak and then a decline. So it is important to keep an eye on the numbers, not only of the cases, but also how many tests are being done. I do think that the end of May, beginning of June is a reasonable estimate for tapering to start. I think it has already started in Bombay and may be soon doing so in Delhi as well. But again, watch the numbers. And will it require interventions? The choice is how high do you want the peak to go? And obviously, if we don't intervene, then we allow the peak to go much higher. We already have mitigations in place. Everything that we are doing in terms of masking or distancing for parts of the population that believe in it and do it, all of that is already mitigation.
You said, interestingly, for parts of the population that believe in it and do it, but we're still seeing large gatherings from various parts of the country. Is there, in your opinion, a need for a severe nationwide lockdown? And we do have a learning from last year on the human rights, outcome of that. But is that the only way out of this? Because if we don't do that, is there a possibility that we'll have mushrooming situations like Delhi across the country, where after Delhi is done, another city will start to suffer for the lack of oxygen and medical resources?
So if we have a severe lockdown, yes, cases will be controlled. A lockdown today means that we won't have cases, or we'll have fewer cases 3 weeks from now, because you will have only one cycle of virus replication. So if you take a 2-week period as how long it takes for the virus to spread to people to get disease, then start to infect other people, then you can take 14 days as that cycle. And if we do something now, 14 days from now, cases will begin to decrease. Now, do we need a lockdown? Is it the only way that we have? It is obviously not the only way that we have. So there are two extremes, the 100% lockdown with all the mitigations around feeding and housing people so that you don't have the human rights crisis. And you have the other end, which is let the virus burn through the population because people are not behaving themselves. And at some point, those who are going to survive will survive, and those who are not going to survive will not. So I think what we need to do is land somewhere in the middle to try and make sure that we have behaviors that we learn. Doing a lockdown each time cases go up is not a solution. Every lockdown has to teach us something. If we say the last lockdown taught us about human rights violations, then let's be very clear about what the next lockdown is going to allow us to do. If it is going to allow us to put in place good public health infrastructure so that we won't have peaking like last time, that we will be able to deliver care to people, that we will have educational policies in place so that there is behavior change, then a lockdown is worth it. If none of that is going to happen, then the lockdown is a delay. It is not a solution.
Doctor, there is a general consensus among scientists now, including advisors to the government, that we will see a third wave in the very least. So how important is it for us as a country to stop being reactive? Because we are reacting to the virus instead of preparing for it.
Let's take a look at influenza. We see 2 waves every year. Right. Do you notice them? We don't have data systems. We don't test for influenza. Therefore, we don't know that influenza comes in 2 waves in this country, right? It kills a lot of people, and it is a seasonal virus. I think that's what's going to happen with SARS-CoV-2. It will become seasonal. Whether we will have 1 wave a year or 2 waves a year remains to be seen. It depends on what the environmental drivers of the virus really are. Now, if you look at what happened with influenza, we don't know anything about seasonal influenza, but we know a lot about H1N1 because we started testing for H1N1 in 2009, and we've continued to test for it. So every time there's a flare-up of H1N1 cases, and H1N1 is now one of the seasonal flu viruses, we know about it. We don't know about the others. I think SARS-CoV-2 will be like that we will have a seasonal distribution of SARS-CoV-2, and it will make the news every time cases occur because we have the tests available and people will use them. But will we see something that is as bad as this wave? I don't think that will be the case unless we wind up with a variant that changes behavior very, very significantly. What we've seen with the variant so far is an increase in transmissibility, and possibly for B117, an increase in severity of disease, but still not a huge rise in the case fatality rate. If we wind up with a virus that has a much higher case fatality rate and is very much more transmissible than the viruses we have now, yes, then we will see a peak or a third wave like this one. Otherwise, I think we will see hills and not steep mountains like this.
Oh, Doctor, you did talk about, this was going to be my next question, variants. There have been some reports, again, this is largely, anecdotal from the state of Karnataka, saying that there may be a variant in Karnataka that is not being picked up by the RT-PCR test because they're getting a lot of negatives, whereas the symptoms display or suggest that the individual has COVID. My question to you is, are we doing enough genome sequencing in the country right now to be able to catch variants as they develop, if they do? And is there a possibility that there are variants that are not, sort of maybe not getting picked up by the RT-PCR test?
So let's start with the second one first, which is if you have symptoms and you test negative, what could the reasons for that be? The first is that it's not being caused by SARS-CoV-2, but you won't know that unless you test for other causes of similar symptoms. The second is the test did not work, and the test did not work because the test does not pick up this variant. It's possible, but given that most of the tests that we have usually target 3 different genes of the virus, it's very unlikely that all 3 genes will not be identified for this variant. What we saw with B117 was that one of the genes, there was a dropout there. So you had the S gene dropouts that allowed you to identify this even without sequencing. So I don't think 3 mutations in the exact locations where the PCRs are is likely. I think a more likely situation is the quality of the tests that are being performed. I think a lot of people don't realize that when you expand from 0 labs to 2,500 labs doing RT-PCR tests, there will be variations in quality. And when you push for a test to be made cheaper than it can be made reasonably, you will again have poor quality tests. So I wouldn't trust a PCR that costs 300 or 400 rupees. Now, if you wanted to figure out whether the cause really is that this is a variant that tests are not able to identify, then it isn't that difficult to just send the samples from those individuals for whole genome sequencing. You don't need to do targeted sequencing. You can do untargeted sequencing, and it will tell you whether it is SARS-CoV-2 or not.
But are we doing enough of that? Which was the second part of my question. Are we studying enough? Is there enough? Are there enough resources for genome sequencing right now?
So genome sequencing has gotten cheaper and cheaper and cheaper. So doing whole genome sequencing now is very feasible. We've barely gone beyond doing sequencing of 1% of the isolates we had. If we were to get to 5%, which was the original goal of INSACOG, I'd be really happy with that amount of sequencing, but it would need to be representative of different geographies and hopefully of different clinical conditions as well.
I do want to ask you this. This is a slightly tricky question. We've had, again, media reports about underplaying of data and numbers in terms of several states. And this is specifically, I'm referring to states of Gujarat, Uttar Pradesh, and some reports from Madhya Pradesh that said that the government was not marking all COVID deaths as COVID deaths, because if someone was COVID positive and died of a heart attack, it could go down as cause of death, heart attack. Now, if there is a sort of gray area in how these things are actually recorded across the country, across various states, does it affect our ability to study the movement of the virus in India and to be able to prepare and understand it better? And is that then detrimental to our response to the virus?
So this doesn't apply to just deaths. It applies to all kinds of data. Are deaths underreported? Yes, they are. Some places do better than others in the quality and the completeness of their reporting. Other states and parts of states do quite badly because a lot of our deaths never have a cause assigned. So if you have a cause assigned, that's between 1/5 and 1/3 of all the deaths that happen in this country. So yes, there is likely to be under-recording, even under the best circumstances, because if you need to assign causality to a death, You need very clear definitions of how it is being done, not only for the person who codes the death, but also for the people who evaluate that information in order to formulate a public health response. And if you underreport death, you underestimate the case fatality rate, you underestimate the infection fatality rate, and you create a false picture of how the virus is doing in your particular population. Now, is that something that's happening here? It's very likely that it is happening, not just here, but in South Asia in general, and possibly in sub-Saharan Africa, which are other places that are seeing an ostensibly low mortality rate with this virus.
Doctor, could the deaths we're seeing right now across the country, could many of them or some of them have been avoided with better preparation?
I think the quality of care is something that we really need to think about. If you have a health system that starts with primary care and then has an appropriate referral process, so that as severity increases, you can refer up the chain so that people get the right kind of care at the right time, then you have a system that works. In India, we don't have a system that works because we don't have the appropriate referral systems. Now, if you or I get sick, we don't go to a primary care provider most of the time. We go directly to a tertiary care hospital to be seen by a specialist. And that's really unnecessary. We are channeling care in ways that aren't appropriate for common morbidities, using up resources that could be better directed to people who really need them. That's something that has certainly happened in this pandemic, that we've had people who can afford to getting, when there is care available, the best kind of care possible, whether they needed it or not. And people who have really needed the care have not been able to access it at all. So are there preventable deaths happening today? Have they happened in the past? Absolutely, there are.
You're at CMC Vellore, which is a teaching hospital that's also a public healthcare, tertiary public healthcare unit. And this is not discussed enough, the pressure that this second wave has put on our doctors, our nurses, our healthcare workers across the country, specifically the ones we're seeing which are overwhelmed in places like Delhi, Uttar Pradesh, and Gujarat. What kind of impact is this going to leave on the human resources within our healthcare system?
I think if you look at what is happening in the country as a whole, when you train as doctors to be able to treat the sick, you want to help people who are suffering. You can't do it only with training. You also need resources to be available to you. And what we've seen in Delhi and other places is that the resources have just not been there. How do you expect a doctor or a nurse or any healthcare worker to be able to function when what they need to be able to function is just not available? I think then you start to think that all of what you have learned, if you're not able to apply it, what value is all of the training and experience that you've built up over time? You're there to help and you can't. So I think the trauma that it's going to have on a large proportion of the healthcare provider population is going to be one that we are going to need to live with for a long time to come. So the kind of care that we can provide to healthcare workers is really important. I was on a call recently with a lot of the Indian medical diaspora. And in the UK, they have this concept that's called pastoral care, which is for doctors to be there, to listen to each other, to be able to vent, when you've been through a traumatic situation. We don't have any of those support systems for doctors or nurses in this country. And I think thinking about the support that we can offer to professionals is critical. I'm very, very lucky to be in a place like CMC, where the community cares about each other and is there to listen. It's hard, but I think in some ways, the fact that we are a community has made things somewhat easier for us than the many horror stories that we all hear from our colleagues who are not in Vellore.
Right, and of course, now we have terrible stories coming out of Delhi of hospital staff who are being assaulted by extremely unhappy family members who've lost loved ones, which is neither the fault of the hospital staff nor the family members, but that level of frustration then builds within, within that system, and it's going to vent in some way, and it's a terrible state of affairs for our doctors.